Bleach smells like safety to civilians. To me, it smells like the absence of something, like a room that has been scrubbed down to remove what was there before. I know what was there before. I have spent the better part of my working life being the person who decided what got to stay and what got cleaned away, and standing in the supply corridor at Caldwell Regional Medical Center with a mop handle in one hand and a vital sign anomaly in my head that nobody had asked for my opinion on. I was very clear on which category I currently occupied. My name is Ruth Callan. I am 54 years old. I walk with a cane on the bad days, and without one on the days when the pressure system is favorable and my left hip cooperates. And on this particular Tuesday, I had left the cane in my locker because the barometric reading that morning had suggested cooperation was possible, which turned out to be optimistic. I have worked the supply and auxiliary rotation at Caldwell Regional for 9 months, a position that exists somewhere below the nursing hierarchy in the organizational chart and functions. In practice, as the job that covers the tasks nobody with seniority wants to claim. I restock. I transport. I mop when mopping is required. I carry things from one place to another place, and I do it slowly. And I do it carefully, and I do it with the same attention I have brought to every task I have performed, in every environment I have ever been placed in, some of which were considerably less forgiving than a hospital corridor in central Kentucky. They called me the janitor nurse. They said I was here to push a mop, not play doctor. They said a woman my age with a bad hip should find a desk job somewhere and stop clogging up the clinical floor. Then, 9 United States Army Rangers came through the ambulance bay doors asking for commander, and the floor went quiet in a way it had never been quiet before. Let me tell you what led to that moment. I came on shift at 6 a.m., the way I always did, through the loading dock, signing in on the auxiliary roster, pulling the day's assignments from the back corridor where the auxiliary staff organized away from the main nursing station. I had taken this job and this shift for the same reason I had taken every unobtrusive position in the 4 years since I left the Navy. Because unobtrusive positions do not require explanations, and explanations were a thing I had decided to stop providing. The ER at Caldwell Regional smelled, as it always did, like institutional bleach, and the ghost of everything the bleach was meant to erase. Underneath it, in the specific register that a person develops after enough time and enough clinical environments, you could identify the subtler notes. The antiseptic cold of the pre-op corridor, the thin sweetness of a blood sugar problem in Bay 3, the particular staleness of recycled air that had been breathed and filtered and breathed again by a night crew running one body short. To the day staff arriving with their coffee cups, this was just Tuesday morning. To me, it was a complete sentence, and I had already read it before I reached the supply cart. I collected my assignment and went to work. The morning ran at its usual pace. Linen cart from central supply to the second floor. Procedure drawers in bays 7 through 10, working around the nursing staff with the practiced invisibility of a person who has learned to occupy the negative space in a room. In a different context, it had been called fieldcraft. Here it was called being unobtrusive, and it served the same purpose. The charge nurse on days was Brittany Lowe, 29, 3 years out of nursing school, recently promoted, in possession of the specific confidence that comes from rising faster than a person has had time to develop the judgment to match. She was not cruel in any calculated way. She was simply at the stage where the hierarchy had recently started working in her favor, and she had not yet learned, could not yet have learned, that hierarchies are provisional, and the people below you in them are not necessarily below you in any way that matters. She made her opinion of my presence clear in the first week, not with hostility, but with the casual dismissiveness that is in some ways harder to argue with, because it doesn't present itself as a position at all. She learned my name on the 3rd week and used it with the specific inflection that converts a name into a category. At 9:15, Brittany stopped me in the corridor outside Bay 6. I had just come from Bay 4, where an 81-year-old man named Gerald Huff had a respiratory rate 3 breaths above his charted baseline and a restlessness that read to me as early compensatory agitation. "The patient in Bay 4, I said. "His resp rate is elevated and he's—" "Ruth." She said my name the way she always said it. "You're on transport today." "I know. I just noticed that. The nursing staff manages the patients. You manage the transport. That's the system." She smiled. The smile of a person explaining something to someone she has categorized as requiring explanation. "Bay 8 needs linen. I'll get to Bay 8, I said. 20 minutes later, the rapid response call came for Bay 4. 3 nurses and the attending physician managed the acute respiratory distress that had, in the intervening time, progressed from elevated baseline to something requiring immediate intervention. The attending stabilized him. The system had caught it. The path to it had been longer than it needed to be. I went back to restocking supply drawers. In the break room at 10, I sat with coffee made 4 hours before I poured it and let myself be still for 8 minutes. I had not always been Ruth Callan, supply cart attendant. The woman the day staff stepped around. I had been a combat search and rescue specialist, SAR, attached to 75th Ranger Regiment for 8 years. The person on the extraction team whose job was to keep the casualty alive between recovery and surgical handoff, in the window that determined whether a handoff was necessary or whether you were delivering something else entirely. The pilots flew the aircraft. The Rangers cleared the ground. I ran everything that happened between the doors closing and the wheels touching down, and the men had called me commander from the second deployment onward until it stopped being a designation and became something accurate. 18 months in Kunar Province, Afghanistan, 31 Rangers recovered under fire. Not one lost on my aircraft. I left the unit in 2020. A blast concussion, the third one, had taken my high-frequency hearing in my left ear and created pressure migraines that made high-altitude operations inadvisable. I wore a hearing aid now, a small beige device the day staff at Caldwell Regional had filed under, older woman, diminished capacity. What the hearing aid actually did was amplify the frequencies I had lost. And the frequencies too low for the aid, the ones that traveled through bone and floor and jaw before they reached air, I had always felt, and still felt. And that had not changed. I finished the coffee. I went back to the floor. At 11:40, Brittany stopped me again. The attending physician on days, Dr. Carl Massey, 44, competent, and the specific kind of tired that comes from being competent in an understaffed environment for too long, had written a transport order for a patient in Bay 9 that conflicted with the standing protocol for that patient's specific cardiac presentation. It was a small error. The kind of small error that builds into something else. I had read the order when I picked up the transport slip, and I had stood with it for a moment the way you stand with something you are deciding what to do with. I brought it to Brittany. The transport order for Bay 9 has a Ruth. Still pleasant. Dr. Massey writes the orders. The protocol for his cardiac profile is... Are you a physician? She asked it without sharpness, as a genuine question, or the shape of one. Are you the attending on this case? No, then I need you to run the transport as ordered. She looked at me with the expression of someone who is being patient with a situation they find mildly exasperating. If you have clinical concerns, you can document them in the auxiliary notes. That's the appropriate channel. I looked at her. I looked at the transport slip. I thought about appropriate channels and what they were designed to accomplish, and what they were, in practice, sometimes designed to avoid. I'll run the transport, I said. She was already turning away. I ran the transport. Dr. Massey caught his own error 40 minutes later and corrected it without fanfare. The patient was none the worse. The system worked. The path was longer than it needed to be. I thought about a ranger named Kowalski, who had taken a round through the upper thigh in Kunar in 2011 and would have died in 6 minutes if I had waited for appropriate channels, instead of packing the wound on a helicopter floor at 8,000 feet. Kowalski sent me a text on my birthday every year. He still had the leg. I went to pick up the mop because Bay 7 needed mopping. I was mopping Bay 7 at 12:18 when the floor moved. It came through the linoleum and into my left hip, the bad one, the one that remembered a hard US-60 landing in Kunar in 2010 whether I asked it to or not, and I stopped mopping and stood very still and listened with my whole body. 3 aircraft. Interblade interval slower than a civilian medevac, heavier, the specific percussion of military utility helicopters at speed. 60 Black Hawks. 3 of them. Landing in the parking lot because the helipad was rated for 1 at a time, and whoever was flying these had not planned to wait. I set the mop against the wall. Not here. You are Ruth Callan. You push the cart. This is not yours, and you made that choice, and you are keeping it. I pressed my back against the wall of Bay 7 and listened to the sound getting larger in my bones. There are military helicopters landing in the parking lot. Connor, the day shift tech, announced from the nurse's station with the particular energy of someone who has never seen this before. He said it like news, like it required announcing. I already knew. I had known for 90 seconds. The monitors at the nurse's station activated with a priority incoming code, not a standard trauma flag, a specific military transport designation that produced a sound I had not heard on a civilian board in 4 years, and that did something to my breathing I noted and did not act on. Dr. Massey appeared from the direction of Bay 9. Patricia Hollis, the overnight charge who had stayed late to cover a gap, was already coordinating the trauma team. Brittany Lowe was at the nurse's station reading the incoming code with an expression that suggested she was encountering something her 3 years of nursing had not prepared her for, which was fair, because nothing in 3 years of civilian nursing would have. The ambulance bay doors opened. They came through the way I knew they would, not rushing, not chaotic. The organized directness of people who have done this before, in conditions where doing it wrong had a body count. 4, with the stretcher. The specific practiced choreography of a team that has transported casualties under fire. 2 flanking. 3 more in tactical spacing behind. At the back, the one in charge. He was mid-30s, the particular quality of young that Ranger Regiment produces, which is not young in any way the word usually means. The build of someone who didn't waste calories. He moved through the entrance and stood and looked at the room and looked past everything that was not what he came for. Brittany reached him first. "Sir, I'm the charge nurse and I need to. What's the fastest route to your trauma bay?" Not a question. She was already pointing before she processed that she had been issued an instruction rather than asked one. The stretcher was through the bay doors. Dr. Massey was moving toward it. I could hear, from the wall of Bay 7, the specific sounds of a trauma intake, the monitor connections, the IV assessment calls, the compressed clinical shorthand of people establishing a situation. And underneath those sounds, I could hear something else. The something else that I had been hearing in variations for 20 years. The specific physiological register of a casualty who was running out of time in a way that the people in that trauma bay were not yet calibrated to recognize. Junctional hemorrhage, the femoral region or the groin, based on the report I could partially hear being delivered. A wound site that standard tourniquets could not adequately address, that required direct compression technique and packing that had to be applied correctly, or it addressed nothing. I knew what correctly looked like. I knew what it felt like under my hands. I had done it in the dark, at altitude, on a moving aircraft, with the specific knowledge that the margin between correct and almost correct was the margin between a man who sent you birthday texts and a man who did not. I pressed harder into the wall of Bay 7. Not here. You push the cart, Ruth. You mop the floor. You are 54 years old with a bad hip and a hearing aid and a mop in your hand, and this is not. The man in charge had stopped moving in the middle of the ER floor. He had stopped the way I had seen people stop when they were running a calculation in their head that required absolute stillness to complete. He scanned the room. He scanned it methodically, the way you scan when you are looking for something specific and you already have a description. "Commander," he said. One word. Flat. Without inflection. Without the rising tone of a question. A frequency being broadcast to a specific receiver. The word landed in the middle of the Caldwell Regional ER, and it had no meaning for anyone in that room. It was not a title they recognized. It was not a name in any staffing system. It was a designation from a world that this hospital had no map for, spoken by a man who had traveled 3 aircraft lengths to find the person it belonged to. Nobody responded. Nobody knew to. The room was full of people turning to look for the source of the name and finding nothing. The charge nurse. The attending. The trauma team. The tech at the nurse's station. Brittany Lowe, clipboard in hand, scanning the room with a slight frown for a person she would not recognize if she found them. I was in Bay 7. I was pressed against the wall, with a mop handle at my side, and my hands were still, and my left hip was aching from the vibration that had been traveling through the floor for the last 4 minutes, and I was looking at the linoleum, because if I looked up, I was going to do something I had been telling myself for 4 years I did not need to do anymore. He took one step toward the bay corridor. He was finding me the way you find something you know is present, by looking for the absence of searching. Every person in that ER was scanning, turning, looking, every person except one. And the one who wasn't looking was the one who already knew. He looked through the Bay 7 window. He looked at me. I looked back at him through the glass, 54 years old, cane in my locker, hearing aid in my ear, mop handle in my hand, and something passed between us that required no words. He had found what he came for. "Commander," he said again. A confirmation, the acknowledgement of a frequency that had found its receiver. I set the mop against the wall. I pushed off the wall. I walked out of Bay 7, my walk, the one that had been logged and flagged and factored into 9 months of being treated as mobile equipment. And in that walk, something folded into a shape too small to be visible for 4 years open to its actual dimensions. Not faster. Not different. Uncontained, the way a thing stored correctly stays intact until it is needed, and when it is needed, it is exactly what it was. The ranger captain, I would learn his name was Captain David Ewan, 1st Battalion, 75th Ranger Regiment, met me in the corridor doorway, and I did not stop to exchange identifications or pleasantries, because that was not what the situation required, and he already knew that. "Junctional femoral, right groin," he said, walking with me toward the trauma bay. "Tourniquet's not holding. He's been in the window for 19 minutes. 19 minutes. I did the math without deciding to. The window was not closed. It was open in the specific way that a window is open when every second spent on anything other than the work is a second that costs something you cannot get back. I need a Combat Gauze Z-Fold direct compression kit, and gloves, I said. My voice came out differently than it had sounded in this hospital for 9 months. Not louder, not harder, but precise in a way that cut through the room the way a scalpel is precise. Because precision is a property of the instrument and not of the force applied to it. And I need everyone who isn't actively supporting to take 3 steps back from the table. Dr. Massey was at the head of the stretcher. He looked at me. She's the one who kept 31 of my men alive, UN said, from behind my left shoulder. Step back. Massey stepped back, not because he was told to, because the tone had already accomplished it before the instruction landed. The gloves were on my hands before I processed putting them on. The wound was exactly what UN had described. Right groin, junctional. The specific geography of an injury that sits in the space between where a tourniquet can reach and where direct pressure can reliably hold without training. The standard tourniquet was in place and doing approximately 30% of what was needed. The other 70% was going to require hands that knew the specific technique and the specific packing pattern and the specific amount of pressure that the anatomy of that wound location required. I had learned it at Fort Benning in 2007. I had practiced it until it was not a skill I performed, but a thing my hands did before my brain registered the directive. I packed the wound. Wound packing with direct compression, not complicated in concept, unforgiving in execution. The difference between the version that works and the version that doesn't is the difference between pressure on the correct anatomical landmark and pressure on the adjacent tissue, which feels identical from the outside and is not. I found the landmark by feel, the specific resistance at the correct depth, and I packed with the combat gauze and applied direct compression with both hands and held it. Counting the rhythm my Benning instructor had drilled in 2007, the count that held pressure through the natural impulse to check whether it was working, which was the impulse that broke the seal. 30 seconds. 45. 60. My left hip ached. I noted it as information and kept counting. The monitor climbed. Steadily, the oxygen saturation moving from the low 80s upward, the blood pressure beginning its slow reversal, the body remembering what to do when it is no longer losing the thing it runs on. BP coming up, said the resident. His voice had the quality of someone saying something they were not yet certain they believed. I kept counting. 90 seconds. 100. Pressure's holding, I said, to UN, standing 2 feet to my left, watching my hands the way a man watches something he has needed to see again. It always held, he said quietly. I looked at the young man on the table, not much past 22. The age that Rangers always are on the table in front of you. And then I thought about nothing except the count and the pressure and the landmark and the monitor. At 120 seconds, I looked at the resident. Take the compression, exactly this position. Do not shift the contact point. Hold it. He placed his hands where I placed mine. He held, he didn't shift. The surgeon arrived at 12:41. I gave the handoff in 45 seconds. Location, technique, compression duration, BP trend, estimated blood loss. She nodded once and took over without a wasted motion. I stepped back. I stripped the gloves. I looked at my hands, the right steady, the left with its small tremor that had started after the second concussion and had never entirely stopped, and I thought about Kowalski's birthday text and 30 others like it. It's enough. It has always been enough. UN was waiting. He pulled a document from his jacket, a printed service record, official. The kind that gets pulled when you need to establish something that isn't in the civilian system, and he turned to face the room. His voice was not loud. It did not need to be. Staff Warrant Officer Ruth Callan, United States Navy, retired. Combat Search and Rescue Specialist, SAR qualified. 8 years attached to 1st Battalion, 75th Ranger Regiment. Deployments: Korengal Valley 2009, Kunar Province 2010 and 2011. 31 Rangers recovered under fire, 0 losses on aircraft. Distinguished Flying Cross 2011, Navy and Marine Corps Commendation Medal with Valor. He paused for exactly 1 second. She has been pushing a supply cart in this hospital for 9 months. The room was silent. Then Yuen's right hand came up. Clean. Straight. Parade ground precise. And the 8 Rangers behind him came to attention in the same breath. All of them. The sound of their gears settling in the motion, a sound that had no business in a Kentucky hospital, and that I had not heard directed at me in 4 years, and that moved through my chest like a pressure wave. The good kind. The kind that does not break things, but only tests whether they are still standing. 9 salutes. In a trauma bay in Caldwell Regional Medical Center. I stood in my auxiliary scrubs, in my bad hip, in my hearing aid, and I came to attention. The motion still resident in my spine, undiminished, waiting. And I raised my right hand, and I returned the salute. 2 seconds. Clean. Complete. Brittany Lowe had both hands over her mouth. Dr. Massey was looking at the middle distance with the expression of a man rapidly revising a significant number of conclusions he had been operating on. The resident who had held the compression was standing very still, his blood-stained gloves still on his hands, watching me with the expression of someone seeing a thing for the first time that they would spend the rest of their career thinking about. Yuen lowered his hand. He looked at me. "I'm sorry it took us this long," he said. "You made it," I said. "That's the part that matters." He nodded. He turned back to his ranger, to the young man on the table who was going to leave this hospital on his own feet. Because the window had stayed open and someone had been in the building who knew how to use it, and the organized machinery of field-trained personnel took over the secondary care, coordination, and the room began to breathe again. I walked back to Base 7. My left hip ached from the hip to the knee, the familiar complaint of a body that had done at sea level what it had learned to do at altitude, which was, by any reasonable comparison, easier. The fluorescent lights hummed above the bay in their usual register. The ER resettled into its Tuesday rhythms. I picked up the mop. Bay 7 still needed mopping. That had been true before 12/18, and it was true now, and the floor did not distinguish between what had happened in the last 23 minutes and what had not. Brittany appeared in the doorway. Her clipboard was gone. Her expression was different. Not ashamed, exactly, but recalibrated. The map she had been using replaced with a more accurate one. She opened her mouth. "Bay 7, I said, before she could. Not unkindly. "Factually, I'll be done in a few minutes." She nodded and left. I finished mopping the floor. I have never needed a title. I had one once and set it down when setting it down was right, and I had been carrying the work that made the title matter every day since, without the title, the same way I had carried it with it. The work does not require recognition. It requires doing. The floor was clean. I wrung out the mop, still here, still whole, still the person they sent for. If Ruth's story moved something in you today, hit the like button and share this with someone who needs to hear it. Subscribe to the channel. We find the quiet ones, the ones carrying something nobody thought to ask about. Drop your city in the comments below. I want to see how far this one reaches.